Hello, everyone. This is Dr. Khan, Executive Plastic Surgery. A warm welcome to the many new members and new listeners who are joining us for another Facebook Live session. This is where I will be able to answer any of your questions that you may have and kind of follow up on the previous day's surgical experiences. So, the most important thing here today that I want to discuss is that you have to do your homework, which means that you have to listen to the surgeon. You have to see the surgeon's videos of as to how and why he or she does the surgeries in the manner that he or she does, and what are the goals of the surgery. In my practice, I want to go ahead and basically discuss that the fundamental, most important aspect of the entire explant process is where the entire implant is removed along with that capsular tissue, so that when the surgery is done, there is absolute peace of mind and commitment and confirmation that the entirety of the capsule was indeed removed. A few hours ago, I finished my case of a nice patient that came all the way from Montana. And this is a lady, young lady. She had her implants from 2009. These were both ruptured on the right and also on the left. And she knew from having watched the many pictures and videos, and especially of the many patients where I have shown exactly how I have removed the entire implant capsule, where the entire ruptured implant was contained in that capsular tissue that forms around the implant, and such that it is done in en bloc fashion, where the entirety of the implant capsule and all inflamed tissue is removed as one system in en bloc fashion. And this is how I did her surgery, where none of the silicone spilled into the chest. The entirety of that capsular tissue was removed along with implant as one system. And in order to accomplish that, I had to remove the fascia of the intercostal muscle, the fascia of the pectoralis minor, the fascia of the pectoralis major inferiorly, the periosteum, perichondrium, and the fascia of the serratus anterior. And this, by definition, ensures and entails that the entirety of that capsular tissue was removed as one system without a break in the capsule, and none of the silicone spill into the chest. I've been able to do this successfully even when I have done 100% total capsulectomy, meaning it was not in en bloc fashion and everything is contained. And the ultimate and the only proof that there is that there are high definition pictures and videos of the chest wall showing complete removal of the capsule. And this is the only proof that the surgery was done in the manner as described. This past weekend, I talked to a patient where she had her explant done by another surgeon, and the surgeon documented that the patient had her total capsulectomy 100% performed. And this was by far not the case, because she had then gone to another surgeon where the exploration was done and the capsule was supposedly removed, which was apparently left behind on the first surgery. So the bottom line here is the only one proof that your surgery is done correctly is you have the high definition pictures and videos of the chest wall showing complete removal of the capsule, because what could be more true than that? The words are certainly true in the operative note, but what authenticates and confirms is the fact that the high definition pictures and videos of the chest wall are taken by the surgeon and given to the patient. So both of the cases that I did today, both of their significant others, the husbands, got the high definition pictures and videos before the patient even left the surgical facility. And this is that bond that the surgeon needs to have, that the surgery was done in the manner as described, in the manner as was consented, and in the manner that the patient's going to be able to see later tonight. And she'll have the peace of mind that all the monies for the travel and the post-operative recovery, the investment in her recovery, the entire care, post-operative care, she will have the peace of mind that the surgery was done. Now, what are the proofs do we have that the surgery was done in the manner as described. Number one, that you're talking to the surgeon, that the surgeon is not doing implants at all. That means not only is the surgeon, but the surgeon's partners are not doing implants. Last year, there was a surgeon who tried to buy my practice, and he told me I can make my practice more efficient if I were to hire another surgeon who would do augmentation, and that this way you would it would allow for me to capitalize on those group of patients who were interested in augmentation. And this is the type of quote unprofessionalism that unfortunately goes on. You have to see not only that the surgeon but all the surgeons in that group are not augmenting at all, and that your surgeon is only explanting, because it takes almost half an hour, 45 minutes, maximum 1 hour to do an augmentation, whereas it takes me approximately 4 hours plus minus to do a proper explant. And this is where the care and attention, millimeter by millimeter dissection, needs to be undertaken in order to completely remove the entire implant capsule and all inflamed tissue as one system. So the surgeon should only be explanting, and the surgeon should be certainly very much so giving you the high definition pictures and videos of the chest wall showing complete removal of the entire implant capsule and all inflamed tissue. The second point is that the surgeon should only be explanting and not augmenting, and the partner should not be augmenting. Number three, the surgeon must send the entire capsule off to pathology, because that is complete proof that the entirety of the capsule was indeed very much removed. Some surgeons do not send the capsules off to pathology because they fear that that will be the proof that the capsule was not completely entirely removed. And if you look at the dimensions of the capsule, if they're like 2 by 3 centimeters and the implant was 325 centimeters, you know with absolute certainty that the surgery was not done correctly, meaning the capsule was left behind. Number four, the length of the incision. The length of the incision should be approximately the diameter of the implant. I saw a video from a patient from Europe. She already had her explant done, and when I saw her surgeon's incision, it was literally almost an inch and a half. How can an entire explant be done on a 360 cc implant from an inch and a half long incision? Remember, the capsular tissue that is at the lower part of the chest, which is when the implant has moved down, is easily removed. But the whole challenge is to remove the capsular tissue in the upper part of the chest and also on the medial part of the chest. Remember, when the implant is placed, it is much further up in the chest and also medial, and over time it just gravitates downward and outward. So many of the surgeons remove the implant and the capsule down here at the bottom, but the challenging part is much further up on the chest and on the medial side. If you go back and look, approximately 5 months ago, I did a Facebook Live with a plastic surgeon from Europe, and she said in her own words, and God bless her for saying this, that she would be able to remove the entire implant capsule at the lower part where the implant is now sitting, but when the surgical dissection needed to be done in the upper part of the chest, it was a challenging part, and she would then cauterize the capsule, and she would then put a drain in and wash it out, hoping that this is going to clear away all the capsular tissue, which is absolutely incorrect. The capsule must be physically removed from the body, and this is why the fascia of the intercostal muscle, the fascia of the serratus anterior, the fascia of the pectoralis minor, the periosteum, perichondrium must be removed, because that ensures and entails the entirety of that implanted capsule is removed. So the four is the length of the incision should be approximate diameter of the implant. Number five, the length of time of the surgery. So this one patient that I talked to on Saturday, her surgeon spent 90 minutes doing an explant, and I will tell you, in my practice, I only remove saline implants, silicone implants, and residual capsules, and I'll tell you with absolute certainty that in 90 minutes, an entire implant capsule cannot be removed completely, definitively. And as you will see, that majority of the surgeons unfortunately use drains. And I'm going to go ahead and address that shortly. So these are kind of indicators as to your surgeon being optimal or not. And number six, your surgeon must be actively discussing how or he or she does the explants, meaning what the surgical technique and what the intraoperative findings are, and that he or she is talking about breast implant illness, and that he or she is basically explaining to you what is the surgical approach. What is interesting about this whole process is if you go to 10 explant surgeons who claim to be world experts, and unfortunately nowadays a lot of surgeons, almost all of them, have on their websites end block specialist or total capsulectomy specialist. If you ask them, show me a video and pictures of the chest wall showing complete removal, I will promise you they will not be able to reproduce that. And they need to do that consistently from one patient to the next, because that's the ultimate proof that the surgery was done. If you get your gallbladder out, who cares? The gallbladder is going to be out. But in this case, when it comes to the removal of the implants and the capsules, every surgeon has their own on-the-job training, their own on-the-job surgical approach, or their own thought process, their own mentality. Majority of the plastic surgeons don't even believe in removal of the entire capsule. The general consensus is the capsular tissue is basically inert. It does not need to be removed. In my practice, I remove all of the capsular tissue because I do not want to leave any potential badness behind. There are a lot of patients who had partial removal of the capsule or incomplete removal of their capsule or no removal of the capsule, and they felt that their symptoms were as if they still had implants. Some patients had worsening of her symptoms of breast implant illness. And so the 3 patients last year that had CD30 positive, they did not need to come back to me for removal of their capsule because it was already removed to begin with. Also, why remove the entire implant capsule and end block or 100% total capsulectomy to begin with? Because if God forbid this is a ruptured implant, you're not going to let the silicone spill into the chest. It's going to be all contained. And that in itself is alone a reason why your surgeon should not be using drains. So if your surgeon is using drains, that's a big red flag in my practice that the surgery was done incompletely, incorrectly. Your surgery was done such that the capsular tissue was left behind, the silicone spill into the chest, and now the drains become mandatory. So if your surgeon is not using drains, that is a very good sign that your surgery went well. The other point here is the drains themselves are problematic because they themselves are a foreign body, and when they sit into the chest, they induce sometimes fluid formation. The fluid can backtrack from that bulb syringe back into via the drain into the chest cavity, and that can be a catastrophe if the bulb syringe opens at night, for example, or the tube in itself may dislodge in and out. Now, the drains certainly are important and they are required when the indication exists. So in my practice, it has been over 7 years that I have used drains. And the reason behind that is in the many explants that I have done, where even when the implant was ruptured, I never let the silicone spill into the chest. I never left the capsule behind. And I had blood loss that was less than 5 cc's in well over 99.7% of the cases, and now the drain requirement is not there. And you can go to YouTube Shorts and see the videos for yourself, and you'll see the blood loss is less than 5 cc's. You can direct message any of my 16,000 or so members, and my patients will be very happy to share with you that the blood loss indeed in well over 99.7% of the patients was less than 5 cc's, and that is direct proof. I happily, willfully, in a very direct manner, give my patients directly post-op or in the post-op clinic the high definition pictures and videos of the chest wall showing complete removal of the capsule, because that's my bond to my patients. And again, that is the only proof that the surgery was done in the manner as described. And this is direct evidence. And remember, this is a lot of transparency, and this is complete transparency, so that you know exactly what you signed up for, so that my patients, as they leave my post-op clinic and when they have seen the pictures and the videos, They have that utmost content in their mind and peace of mind that the surgery was done in the manner as described. Remember, there are easy surgeries and there are hard surgeries. I find from looking at the many social media posts, when the surgeries are easy, or the case is above the muscle, or the case went smooth, the surgeons are very good about explaining how and what they did. But when it comes to the many other difficult cases, those surgeons do not share the videos, pictures on social media. And this is a problem because you have to be transparent with your patients. And this is why, in an ideal world, if I were to set up the rules as to how things should be done, the surgeons must take high definition pictures and videos of the chest wall showing complete removal of the entire implant and capsule, and show to the patient and give to the patient directly, because that is the one and only ultimate proof, along with the other reasons that I mentioned that include, again in summary, that the surgeon is only explanting and his or her partners are also only explanting. Number two, that the high definition pictures and videos are given of the chest wall and certainly cutting open of the implant capsule on the table. It is not a HIPAA violation to give it to the patient herself. Number three, the length of time of the surgery is approximately 4 hours plus minus. If it's any shorter, like 2 hours, there's a big red flag and a question mark in regards to how the surgery is done. Number four, the length of the incision is approximately the diameter of the implant. Number five, the capsules are sent to pathology, so that is the proof. A patient of mine can go to the pathologist and ask, can I see my pathology capsule samples? And you will see exactly how much and what the content and what is the capsular tissue that was removed. And that is the ultimate proof that the capsule was removed in the manner as described, because you will see the consistency of the capsule. So again, this is all a surgery where there is sincerity, there is complete, from the bottom of the heart, the surgeon's goal is to remove all the badness. So in my case, I have taken care of a lot of patients where there was residual capsule. So in those cases, and in any case, if I find anything questionable, or if I find anything abnormal, I remove it. So in my practice today, I removed, my first case was a breast cancer patient. I removed surgical clips that were right in the proximity of the implant. I removed alloderm, which was cadaveric skin. Remember, it is foreign material, it must be removed. I also removed the entire implant capsule, and the patient ended up getting what is a flat chest aesthetic closure. The worst case scenario I find are those patients that have already gone for an explant and the surgeon swore that they did the right surgery, and there is documentation supposedly that the total capsulectomy was performed and the patient does not improve, and she knows that her surgery was compromised, and now the patient has to seek another surgeon out and get the proper residual capsule done. Do not be that patient where, just this past weekend I talked to a patient who said that her insurance covered the explant, and I'll tell you, there is no such thing as insurance covering the explant, because the insurances don't even recognize capsule removal. They don't recognize the breast implant. Unless there is no ICD-10 code, the amount of reimbursement is literally shabby, and it will not justify the 4 hours of surgery that the surgeon will spend. Remember, this surgery is about precision, about accuracy, about completion, about sincerity, about being comprehensive and detailed and honest and sincere to the patient. This surgery is not about speed. I see some surgeons that are doing a supposed explant, a lift, and fat grafting in 2.5 hours, and this is virtually impossible. If you called this surgeon's partner, they would be putting in implants. And remember, this is an organized scheme by this group that they're trying to capitalize on explants as well, and you have to be very careful and you have to do your homework. These are the same group of people that will call my patients up, for example, and say, turn around, Dr. Khan's anesthesia is questionable. I will recommend that you then listen to my Facebook Live and the YouTube Live that I did with my anesthesiology team, and listen to my anesthesiologist directly. And as you will see, I have taken care of a lot of doctors' wives, nurses in my practice, where they are very comfortable with twilight deep sedation, and they feel very comfortable in regards to the surgical approach, where you have twilight deep sedation. To date, where not a single patient has woken up during their surgery, and the patients are completely amnestic to their surgical experience, and they are not paralyzed, and they're breathing on their own, and they are woken up from the surgery in a very nice, practical, fast way, as opposed to general anesthesia, which is still relatively safe. But I am not a big fan of putting a tube, paralyzing the patient, putting a tube down and letting the ventilator breathe for the patient, which is done safely every day. But I say if there is a better, more safe, practical approach, utilize that. Now, the other thing I want to mention here is you should and must watch the YouTube videos, YouTube Live, YouTube Shorts, and YouTube videos in order to truly understand, comprehend what the surgeon is about. You need to also talk to the surgeon's previous patients and validate the surgeon's experience. Now remember, in my practice, I make only a horizontal incision at the bottom of the breast tissue at the inframammary crease, where the diameter of the implant dictates the length of the incision. And then I'm always, in the majority of the cases, below the muscle. And when I am below the muscle, I stay below the muscle. I do not go into the breast tissue above the muscle. So this is one of my hallmark definitions, where I do not cut into the breast tissue above the muscle. If this is the muscle, I'm always below the muscle where the implant is, and right on top of the rib. So I do not go into the breast tissue at all. That's fact number one. And fact number two, I measure the distance from the nipple down to the crease, and if it's 5.7 centimeters, that was the case in my last patient today, I measure on the left, and I make sure if it's 6.2, I will cut 5 millimeters extra so that I'm able to make the two sides symmetric. So I'm not touching the breast tissue, and I'm not touching, I'm basically measuring the distance between the two sides so it is equal, so that there is symmetry that is achieved. Now, the reasoning behind this is when the patient gets her next mammogram, or she does her next self-monthly breast exam, you will see the patients do not have an altered sensation of the nipple areola complex. They do not have a altered feeling, palpation of the chest breast tissue area, so that now they can screen effectively for breast cancer. Remember, 1 out of 8 or 9 patients will get breast cancer. So if you have a room full of 100 patients, ladies, of the 100 ladies, almost 12 plus minus will get breast cancer. So it is very important not to alter or change the physiologic state of the chest breast tissue area by operating around. So I find a lot of unfortunate young ladies that are going to surgeons who are making a lollipop anchor lift or a S lift, J lift, and they clearly did not need this formal lift. The surgeons are always putting drains in, and I'll tell you that's an absolute big no-no in my practice, because the drains are not required when the surgery is done correctly. And remember, cut around the nipple areola and cut up and down. Many patients report loss of sensation of their nipple, or they have difficulty nursing. Small fraction of them that they have pins and needle sensation. Sometimes they have irregular hypopigmented scars, white scars around the nipple, big hypertrophic scars or keloid type of scars. And the anatomy and the physiology of the breast tissue can certainly also be altered as a result. Fat grafting as a direct result is also I'm not a big fan of at all, because some of the fat will inevitably die and get absorbed by the body. Some of the fat will form clumps of this nodular fat and may deposit at different densities, because the fat is laid out and spread out in different layers. And what happens is, now when you do a self-monthly breast exam, you may have some acute and chronic pain, or you may have an altered sensation. Some of the fat may take care, may not take care. So some patients have had 2-3 different sessions of fat grafting. Some patients, it's actually contraindicated, especially if they have had a lumpectomy and they have markers, because now you might feel a mass and it might truly be fat necrosis, or it might be what may be a recurrence of basically breast cancer. So remember, you have to be very careful. Do not touch. In my practice, do no harm. Do not touch unnecessarily, and do not cause more problems. Yes, in the name of aesthetics, it's just important, and every patient is certainly entitled to it, but not at the ill health or compromised health compromised results and bad results ultimately. So very important. Now the other thing for the many patients, they need to realize, breast implants are not lifetime devices. Eventually the result is only going to be bad because they're not lifetime devices. Plus minus the last 10 years, look at the gummy bears that are removed from this nice young lady that came from Montana. She had both of her silicone implants ruptured and they were all contained. No need for drains, no need for the unnecessary lift, and we will see physiologically how she's going to do well post-op. Now the point here is that you as a patient, you need to understand what are the implications behind having breast implants, and there is no other better uh, area or no other better uh, uh, communication than this. This is the breast implant certain labeling recommendations to improve patient communication guidance for industry and Food and Drug Administration staff. This was a document issued on September 29, 2020, and US FDA. And this has in it, if you read between the lines, all what one needs to, must know if you have implants. It should have said guidance for patients to improve patient communication. And as you will see, they basically outline the black box warning. This is breast implants are not considered lifetime devices. The longer people have them, the greater the chances are that they will develop complications, some of which will require more surgery. So that means if 100,000 patients, 22-year-old get implants, be it saline or silicone, over a period of time, the end result is only going to be bad, meaning they're going to rupture, they're going to cause capsular contracture, they're going to have issues. What are these problems? Let's go ahead and back a look at this. Page 11, and remember, they want you to initialize patient initials. Risks of breast implant surgery: breast pain, skin on nipple areola sensitivity changes or loss, asymmetry, impact of aging or weight change on size and shape of the breast, infection requiring possible removal of the implant, swelling, scarring, fluid collections, hematoma, tissue death, inability to breastfeed, complications of anesthesia, bleeding, chronic pain, damage to surrounding tissue such as muscle, nerves, blood vessels. And as you will see, if you look at page 12, it says over here, my physician has discussed these risks and has provided me with the patient information booklet brochure, including the box warning, patient initials. If you look at the next, you will see, look at the top of page 14, not my words, these are the words of the FDA. Quote, I understand that silicone can migrate from my implant into nearby tissues, chest wall, lymph nodes, under the arm, and organs, liver, lungs, where it may not be possible to remove. I understand that all breast implants can interfere with mammography and breast exams, which could delay the diagnosis of breast cancer. This alone should be a reason to not get breast implants, period, because why would you want to delay the diagnosis of breast cancer? Mammography can also cause breast implants to rupture or leak. There's so many patients I've talked to who have chosen not to get mammograms because they're afraid they might get hurt or rupture the implants, and now their breast cancer screening is being affected negatively. The next point, I understand that, quote, I understand that all breast implants contain chemicals and heavy metals. I understand that most of these chemicals stay inside the shell of the implant, but small quantities have been found to diffuse gel bleed through the implant shell of silicone gel-filled implants, even if the implant is intact and not ruptured or leaking. So look, they're telling you gel bleed is occurring. And so these are real problems that they're going to go to the silica is going to migrate to the lymph nodes. Not in all, but how do you know you're not going to be the one? And as you will see, I understand that the long-term risks of breast implants may include painful or tightening of scar tissue around my implant, capsular contracture, uh, rupture or leaking of the implant, wrinkling of the implant, visibility of the implant, shifting of the implant, need for reoperation. If I read this, or if I read this to someone who's interested in getting implants, like a 25-year-old person, she should run away. If I am the 25-year-old lady who is interested in getting implants and I read whatever I have read, these are not my words, this is not AI generated, this is words from from the FDA, and this is also highlighted by the manufacturer as well, the gel bleed phenomenon that occurs. I would run away from these implants as much as possible. Why would you want to harm your body? And this is the whole purpose. Remember, breast implants were once basically taken off the market. They were banned from 1992 to the year 2000. A lot of harm, and the FDA stepped up. And now, what is ironic and interesting is that saline implants were permitted and silicone implants were allowed for reconstructive purposes. And I say this, I was on a Zoom meeting with another plastic surgeon, and this plastic surgeon corrected me and said, well, the silicone implant was not banned for reconstructive purposes. And I said, how shameful for this plastic surgeon to even mention that. They should have been banned for reconstructive purposes, because a silicone implant for cosmetic reasons is the same risk that this patient with breast cancer is going to have if you put the silicone implant in. And how incomplete and uh, how wrong of someone to not extrapolate the same risks of a silicone implant to someone who's getting reconstruction. Meaning, why would you want to harm someone who's going to get implants for breast cancer reconstruction? So ultimately, these implants, you need to know, if you have them, if you're interested in getting them, what exactly it means to basically understand the risks, so that if you have problems, you know that you're going to get answers. Just this week, I talked to a patient who said that she had talked to a surgeon who said that the capsules get dissolved by the body, which is absolutely incorrect. The capsules, even 20 years later, I have removed, they still basically linger around. They are scar tissue, and they very much absolutely need to be removed. And in my practice, I remove them so that we know what we're dealing with. A surgeon cannot look at the capsule and say, well, it's benign appearing and I'm not going to remove it completely and I'm going to cauterize it. Absolutely wrong. I had a plastic surgeon from France who still follows me regularly, and he said, well, doc, I don't buy that you remove the capsule completely from all your patients. I said, well, guess what? Why don't you reach all my 16,000 or so members? How many of those patients that I've given, all of my patients that I've given the high definition pictures and videos to, and you can ask each one of them. And they have their videos, and they know that the capsule was indeed very much removed, because they have high definition video and photographic evidence of complete removal of the capsule. Now remember, if I didn't remove in the capsule, from a financial perspective, I'm only better off putting in implants, because I would rather put in 3 sets of implants versus one explantation case. So let me say this again. It takes me 4 hours to do a explant on average, plus minus. My first case took longer because it was a longer case. In the same time that I take to explant, I could easily have done 3 or 4 augmentations between 2 rooms. And the point here is, it is financially more rewarding to basically put in implants. And remember, I choose not to put in implants. I only put in 1 implant in my career. Like some of my patients have pointed out, I'm the only plastic surgeon who purposefully, deliberately did not augment, and only did 1 case in order to get board certified. And I never in my career ever put implants in, because I do not believe in them from the very beginning, and they only ultimately harm the body, and I felt strongly that I would not do something that I do not believe in. The other point here is, it's not only financially not rewarding to be putting in implants, but also it is physically very demanding to be doing a surgery standing up for plus minus 4 hours in a millimeter by millimeter dissection. And if you ask me, if I were to show some surgeons how to do the surgery, majority of them would not even attempt to do it, because they want to go in and out and be done. Their hearts are not in it. They're not believers in total removal of the capsule, so they will never do a surgery that they're not going to want to believe in. And so if it's not coming from the heart, the surgery will never be done correctly. And you will see there will come a time for all of these surgeons, and including myself, if they are true to their word, time will test each one of them. Because there will come a time where one patient will say, how come I never got the video, a chest wall capsule video showing chest wall video showing complete removal of the capsule? How come my incision is so short? How come the length of the surgery is 2.5 hours where I got this done? Where how could it evenly be humanly achievable that an explant was also done and the time that a lift was done? Where the capsule was not sent to pathology, how come my capsules are not being sent to pathology? How come you're not accepting on social media that breast implant illness exists? Remember, these are all facts that you as a consumer, as a patient, need to do. You need to do your homework. You need to do that investment in your recovery so that when you get done, you have that peace of mind you chose the right surgeon. Do not choose a surgeon because a prominent influencer is telling you you need to go to this surgeon. Do not choose a surgeon because another patient was paid, another influencer or social media personality was paid in order to promote a surgeon. Do not listen to another patient who basically was improvised into basically supporting something that is not true. So the bottom line here is do your homework, do that due diligence, so that when you look back at your surgical experience, you have that absolute peace of mind that your surgery was done. In my practice, there is complete transparency. As you will see, I'm very much hands-on. We have a practice in California, Greater Los Angeles, California, and also here in Michigan. And this is where I see my patients. I talk to my patients. I'm very much directly involved. I don't have a PA. I do not have a nurse practitioner. I do not have a nurse or a medical assistant or an office manager who has no concept of medicine to be talking to patients and giving medical advice. That is absolutely bad and wrong medicine and consistent with malpractice when you have someone as an office manager giving medical advice to your patients. So talk to the surgeon directly. Do not see your surgeon the morning of the surgery and be fooled and be naive into doing a surgery where you ultimately will be only regretting. Be very careful as you navigate to the next level. Talk to the patients, certainly talk to the surgeons, not once, twice, and be very content and do your homework. Look at the surgeon's videos. Do not look at the videos of the surgeon talking. It is very healthy and good to listen to a lecture like this, but most important, you have to go to the YouTube videos, YouTube shorts, and YouTube lives and see the cutting open of the capsules and the implants. I'm very happy to announce I'm going to be making a website where I will have all these graphic pictures and videos, patient testimonials. Also, I will include the before and after pictures and videos. Now, this was a discussion I had with a patient yesterday in clinic where she was asking about before and after videos. Now, I want to go ahead and mention this is something you need to be very careful of. I went to a surgeon's website and there I saw she had all the best pictures that she could have chosen. Some of them appeared to be photoshopped, and you do not want to be fooled into thinking, oh, well, this is the surgeon's results all the time. That is incorrect. If someone has a ruptured implant, that right side ruptured implant is going to be different than the left because this is a lot more inflamed. Someone has a radiated chest. Someone has had 4, 5, 6 surgeries on one side and 6, 7 surgeries, 8 surgeries on the other will have different results. Someone has had a grade 4 capsular contracture versus grade 2 on the other side. Someone has 800 cc implant on one side or 500 cc implant on the other side. Someone was done by a board certified plastic surgeon, someone was not. Someone had implants above the muscle, below the muscle. So you yourself as a patient cannot compare and say, well, if I end up going to this surgeon, I'm going to be ending up just like this picture number 11 on her website. So you want to be very careful as you look at these pictures and videos. When I was making my website manufacturer designer said, well, we have some stock photos and pictures. And I said, absolutely not. One of my patients that I talked to, she told me She looked at a surgeon in California in Los Angeles, and she saw a model. She saw a picture, a very nice, excellent result of this one patient. When she looked at another surgeon in Dallas, she saw the exact same picture on the same on another surgeon's website. And this is what I'm trying to tell you: is do not be fooled into thinking that, you know, these surgeons put the best pictures. I have on my camera almost 500,000 pictures. I can post the top 20 and you will be, wow, I'm going to go. No, I do not want to do that because I do not want to trick you. You have to understand there are so many variables, from the patient's ethnic skin background to the patient's age, multiple surgeries, patients on prednisone 20 milligrams, and this other patient is not on any prednisone. She's going to have totally different skin recoil and results, having had her prednisone for like a year period, for example, or even 3 months. The results are going to be different from this one patient to the next. So be careful as you look at pictures and videos, because the general consensus is, well, this surgeon has very nice videos, very nice website. That is not how you choose a surgeon. You do not choose a surgeon because they have 35 years experience. This is another patient I talked to recently. She talked to a surgeon who had almost 35 years experience, had phenomenal career, and she went to the surgeon, and guess what? The capsules were left behind, the silicone spill into the chest, and now she's going to seek me out for residual capsule removal plus residual spilled silicone removal. You want to choose a surgeon not because they themselves made a website and said we are the top 10 surgeons, because they self-promoted. This is not how it's done. You do not choose another surgeon because you went to this recommended list of surgeons. Who is this person who's making this recommended list? Are they board certified plastic surgeons who have 30 years experience in explantation and now they're making the right call? No, these are all financially driven Facebook sites, Instagram sites. I want to show you an email that I got from another Facebook group owner who reached out to me and said, we have so many thousands of Facebook members. Please donate to our cause and to our Facebook group page. We will promote you and give you an asterisk and highlight and promote you, and we'll send you so many patients that you will only be grateful if you just make a donation. And I said how corrupt, it violates stark law violations. It is unprofessional, unethical, and certainly unlawful. And these websites certainly will only get into trouble because whenever there is kickbacks, these are financially driven Facebook sites. Patients who unfortunately do not comprehend, if this is someone who's a nail salon owner last year, now is promoting another surgeon and now capitalizing on financial kickback and feedback and incentivizing patients to go to this surgeon because she's now being paid influencer in order to promote patient traffic to the surgeon. And this person has no concept of plastic surgery. She's not even a nurse. And the bottom line is, you want to be very careful as you navigate in this very tricky waters. Nowadays, every single plastic surgeon, pretty much, you just name the surgeon, you will see on their Facebook, on their web page, the World Explant Surgeon. You want to be very careful with this. Many surgeons are now explanting and they're claiming themselves to be the world expert. If you look at what I mentioned earlier, these are all, you have to have that support, you have to have that confidence in the surgeon. And again, I will end with this: the high definition pictures and videos of the chest wall showing complete removal of the entire implant capsule. That is the one and only and ultimate proof that the surgery was done in the manner as described. So hopefully you found this informative. We're going to have a very nice Facebook, YouTube, Instagram live on April 6th with one of my former patients. So absolutely do not miss this. And I hope to have these regular question answer sessions so I can answer each one of the questions directly. And if I ever do not know anything, I'll be the first person to say I do not know. We need to do more research. So thank you very much. Hopefully you found this informative. Take care. All the very best. Thank you.